Okay, good evening, ladies and gentlemen. Welcome to our webinar on breast cancer and immunotherapy. Okay, before we introduce Dr. Tan, allow me a little bit of time to introduce to you briefly about SCAN in case you do not know what SCAN is all about. So we are from SCAN. My name is Bunui. I'm the president of this cancer NGO. Our full name is Society for Cancer Advocacy and Awareness Kuching. So we are based in Kuching basically. And in the past many months, due to COVID-19 pandemic, we actually organized many webinars on topics and issues related to cancer patients, survivors, related to lifestyle, related to cancer information and knowledge. Yeah, so tonight we are going to be talking to this immunotherapy. And at the same time, I'd like to share that our society is also offering a twice a week helpline to help especially the newly diagnosed cancer patients for any inquiries related to emotional support or inquiry about information related to how to go about getting cancer information. Yeah, support. Yeah, at the same time, I would like to make sure that everyone put yourself on mute so that we have no interruption from the rest apart from the speaker. Yeah, and also at the same time, I want to say that we have actually just launched a book last year. Is a guidebook for cancer patients in English. So you have cancer, what now? A guide for patients. So that was since last year. And this year, in fact, today, we have actually launched the translation of this English book into the Chinese version, 你患癌了怎么办？一份给患者的指南, as well as the BM version, Anda ada cancer. Apa yang harus dilakukan? Panduan pesakit. So these books are now made available and you can order through our Facebook Messenger, our helpline, and the number we can read out to you later, or you can just go to our Facebook page. If you would like to acquire a copy, which is being sold at 15 ringgit per. Yeah. And all right, so back to our webinar this evening. Let me do a very brief introduction about Dr. Tan. Dr. Tan Chih Kiang is residing at Tung Shin Hospital as a consultant clinical oncologist. Formerly, he was working at radiotherapy and onco department at National Cancer Institute, Putrajaya, from 2019 to 2020, mid of this year. And in fact, he was actually graduated from International Medical University, followed by Master in Clinical Oncology from MU in 2017. And I understand that Dr. Tan has been very actively involved in a lot of clinical research, yeah, and participated in numerous clinical trials. Yeah, this is something good for us to know, as that he actually participated as co-investigators, right, in many trials. Okay, and for those who are from Kuching, maybe you have seen him before in RTU. He actually worked in a clinic as a clinical oncologist in our SGH RTU from 2017 to 2019. It doesn't matter whether you have met him before, but tonight you get to see him and hear from him. And then we are going to learn from him about this topic about immunotherapy for breast cancer. And as most of us will probably know, in cancer treatment, those terms that you have already heard of from time to time is like radiotherapy, chemotherapy, hormonal treatment, and some imaging tests for diagnosis and so on and so forth. But as far as immunotherapy is concerned, I think many of us may not be familiar and may not know much how it actually can help breast cancer treatment, help in breast cancer for breast cancer patients. So tonight, this is a very good opportunity. We're going to hear a lot about this topic, breast cancer and immunotherapy from Dr. Tan. So now the floor is yours, Dr. Tan.
Okay, thank you very much to Madam Sue for the kind introduction, and thank you very much to SCAN for the invitation. It's my pleasure to be here with you all tonight virtually. Okay, so let me just share my screen. Okay, So I hope that I'm loud and clear enough. Okay. So today I'll be sharing with you guys or ladies with regarding this topic, breast cancer and immunotherapy. So I'll briefly talk through breast cancer and immunotherapy, and then towards the end we will have a Q&A session where you can actually ask any questions, and then I'll try my best to explain to you so that you could understand my disclosure and disclaimer. And then, so the outline for my talks for tonight is that I will be talking about breast cancer in Malaysia. How's the situation like? And then what are the risk factors of breast cancer, signs and symptoms? And then the importance of breast cancer screening, and what are the subtypes of breast cancer and the general management of breast cancer. And finally, we will be talking about immunotherapy and immunotherapy in breast cancer itself. So firstly, based on our local Malaysian data, which is the Malaysian National Cancer Registry, the latest one being from 2012 to 2016, we have about 21,000 over new cases of breast cancer in that 5 years. So that worked out to be more than 4,000 cases per year. But generally, I would say that probably the figure might be a bit lower than the actual one, because these are based on those who actually registered and those who actually reported out. I'm sure there might be some cases being diagnosed, but unfortunately are not able to being registered and therefore not captured in this registry. And in terms of the three main races in Malaysia, the risk of developing breast cancer is actually higher in Chinese, followed by Indian and Malay. Despite the population of Chinese and Indian are much more smaller than Malay itself. And if you look here, breast cancer is actually the commonest commonest cancer of all cancers in Malaysia, both generally as well as in female. And unfortunately, if you look at this graph here, is that almost 47%, 48% of our patients actually presented in stage 3 and stage 4. So why are we emphasizing this is because I think, as we know, the earlier the stage of a cancer, the higher the chance of a cure, with the treatment. So if let's say someone have stage 4 disease, then obviously we are not talking about cure here, but more of like to control the disease, relieve the symptoms, or try to prolong the life. And when we talk about stage 3, even though the disease has not spread to anywhere and the treatment intents are still for cure, but because it's already stage 3, so actually there's a high risk of recurrence for that. So if you look at our neighboring countries, like just Singapore, for instance, if we were to compare, their stage 4 is just about 9.5%, which is less than 10. Whereas for us, it's 22.8%, which is more than double the amount. And if you look at the earlier stage, which is the stage 1 and stage 2, theirs is about 71%. And for us, it's just close to 50. Again, 20% lower than them. So because of that, I'm very sure that the outcome of breast cancer patients in Malaysia will be generally worse compared to Singapore. That is not sometimes because of the availability of treatment or access to drug, but just looking at the presentation itself alone, you can really tell that the outcome or the prognosis of the patients in Malaysia will be poorer compared to our neighboring countries. So when we talk about risk factors for breast cancer, of course, these are not the only list, but the major ones. So we divide them into two groups. One is which is a non-modifiable, and the other one is the modifiable. So the non-modifiable is like age. Of course, we know that as someone increasing in age, so there's always a higher risk of getting cancer, both other cancer as well as breast cancer. And the others are like early menstruation, late menopause, late first childbirth, family history of breast cancer, and of course, some genetic abnormalities, example, the famous BRCA gene, also can increase your risk of getting breast cancer. But all these factors are not something that you can do or change it. But the other factors are mainly associated with lifestyle, like obesity, smoking, alcohol. So those are things that will increase the risk of getting the cancer as well. But these are the factors that something that you can do to modify or change it, to reduce your risk of getting the breast cancer. And what are the signs and symptoms of breast cancer? So if you look at the diagram here, so generally when we say that you try to see whether is there any signs or symptoms of having breast cancer, is that you look for whether is there any changes in terms of the size or the shape of the breast, and whether is there any lumps or swelling, or whether is there any changes in the skin itself, such as dimpling or puckering, and then even changes to the nipple itself can be a sign and symptoms of breast cancer, or even discharge or pain. bear in mind that not all breast cancer patients will present with breast pain. In fact, I would say that most of the patients will not present with pain as one of the first symptoms. So if you look at the diagram here, so what are some of the signs and symptoms or signs that can present on the breast, which may be because of breast cancer, is like the thick. We start off with the first element on the top left. So you can see that, sometimes they can present with a thick skin. So all these changes that I'm talking about are new changes. I'm not talking about something that has been there, since a person attained puberty, and then they have this issue there. Because the thing is that not everyone is the same. There's always variables, changes or difference between individual. Even for a lady, both the breasts might not be the same size, or they might not be the same shape as well. So if let's say those changes or those are present since the puberty time, then that is not something that we should be worried about. But what I'm talking about is more of like something that's not there previously, but now have changed to present as one of these signs. So we are looking at like thick area on the skin, or there can be a dimpling. Okay, that is because potentially there's actually a lesion under the breast, which is actually trying to pull the breast tissue down. So therefore, they present as a dimpling. So nipple crust, red or warm area over the breast, new discharges, skin sore, bumps, growing veins, sunken nipple, new shape or size, like I said, changes, right? Orange peel skin, or even hard lump that you can feel, which was not there previously. So, of course, again, not all these signs and symptoms are attributed due to breast cancer. It could be something which is just like a benign condition. In fact, if you're talking about just lump itself per se, almost about 80% of lump detected in the breast are actually benign condition and not breast cancer. So if you have noticed any of this, please do approach your doctors as early as possible so that they can do the examination and the proper investigation to rule out breast cancer. So please don't wait. So let's talk about breast cancer screening. Actually, I would say that breast cancer screening is something very important, and I'd like to emphasize this because if you look at cancer in general, not all cancers has screening program or screening method. Okay, and it's good that actually breast cancer is one of the only few cancers where there's actually screening available. So what are the screening available for breast cancer? In the sense that you can do this breast self-awareness, BSA, okay, where you actually look at the breast, you can feel it, okay, and if you look at it and when you feel it, there's any abnormalities being noted, then please respond, by going to the nearest clinic or hospital or to your doctors, to do further investigation. So who should be going for the breast cancer screening? Of course, there are a lot of guidelines, a lot of recommendation around the world. Some will say that, from 45, some will say that from 50 years old, but generally 45 to 50 and above, up to 74, you are recommended to actually do a mammogram every other year. And then if let's say you are between 40 to 49, you can consider to do the mammogram, especially if you have high risk factors. And for those who are less than 40, if let's say a breast screening need to be done, then normally we will suggest ultrasound rather than mammogram. This is because for younger ladies, normally the breast tends to be a bit more dense. Therefore, a mammogram might not be a suitable tools for them to pick up any abnormalities within the breast to detect the cancer early. So what are the risk factors that will put you as high risk? Therefore, you might need to consider to go and do this breast cancer screening earlier. Is that if you have a first degree family with breast cancer, meaning that your parents or your siblings or your children has breast cancer, so that will put you at a higher risk. And then, of course, if you are a known case of BRCA mutation, that will put you at much, much higher risk of having breast cancer and other cancer as well, such as ovarian cancer. And of course, if you have history of underlying breast diseases like atypical hyperplasia or ductal carcinoma in situ or lobular carcinoma in situ, these are the precancerous lesions in the breast, which over time has a risk of turning and become cancerous. So if you have any of this, that will put you at high risk of developing breast cancer, and therefore you might need to undergo the breast cancer screening much earlier than the general recommendation. So what are the subtypes of breast cancer? So I would like to share that actually breast cancer is not one disease. What it means by that is that when someone is being diagnosed with breast cancer, in terms of the management, in terms of the treatment, will not be the same between individuals. Because sometimes we do often hearing patients saying that, doctors, why am I sitting outside in the clinic just now when I chit-chat with the ladies next to me? She had this treatment, but I don't. Or I have this treatment, but she didn't. So why is it different? This is because breast cancer is not one disease. Therefore, the treatment is not like one size fit all kind of thing. So it's very much tailored to individual. Okay, so if you look at the breast cancer classification, there are actually numerous types. This is in fact already a simplified version. And with the advancement in technology and science every single day, actually much more subtypes are being identified every single day. And in terms of the management for all these subtypes, they might be different, especially in the near future. So, but not to confuse you further, okay, what I'll do is that I'll classify them as the three main type, which is mainly the estrogen receptor positive, or we call it the hormone positive, or the HER2 positive, and finally is the triple negative. Of course, the commonest are still the hormone receptor positive cases, contributed about 2/3 of the total breast cancer patient. And why are these subtypes very much different is because generally the treatment will be different as well. As you can see here, for those with hormone receptor positive, of course, you'll be probably using endocrine therapy or hormonal therapy, which we what sometimes we call it to be. Or for those with HER2 positive disease, then anti-HER2 might be part of your treatment. And for those with triple negative, where anti-HER2 and endocrine therapy or hormonal therapy is not suitable for you, then we talk about chemotherapy or immunotherapy, which we will be talking about later on. So in terms of management of breast cancer, generally, surgery is one of the very important aspect of the treatment. So it can be a mastectomy, meaning that they actually remove the whole breast together with the lymph nodes, or breast conserving surgery, meaning that they actually just remove the cancerous lesions, the lump itself, and then they spare the breast itself. Okay. Other treatments are like chemotherapy, radiotherapy, endocrine or hormonal therapy, in fact, targeted therapy and immunotherapy as well. So in terms of the management of breast cancer, it will be a combination of the above. But the treatment will be very much depending on two main factors, which is the patient factors and disease factors. So when we talk about disease factors, meaning that the subtype of the breast cancer is very important to determine what are going to be your treatment like I mentioned, whether is it hormone positive, HER2 positive, or triple negative, the stage of the disease, and then the other one is the patient factor, whether what is the age of the patient, whether the patient is actually fit or not, whether the patient have any underlying medical problem, which will make them not fit for any of these treatments that we are going to be recommending to them. So a combination of all these factors, then the doctors will come up with a management plan for that particular patient. Therefore, because of that reason, not everyone's management will be the same. Even though someone might have hormone positive breast cancer, the treatment or the management might be a bit different as well between the individuals. And let's talk about a bit about individual subtype of this breast cancer. So when we talk about the hormone receptor positive breast cancer, like I mentioned, is the commonest, about 2/3 of the total breast cancer patient. So in someone have hormone receptor positive, then of course hormonal therapy or endocrine therapy may be part of the treatment. So the hormone therapy can be used in both the early stage as well as in the advanced stage. So some of the example of hormonal therapy that you have probably heard before or that we can use is like tamoxifen, or another class called the aromatase inhibitors, which consists of letrozole, anastrozole, exemestane, and the others endocrine therapy is like fulvestrant, CDK4/6 inhibitors. And of course, as times goes by, this list actually gets longer and longer because we always have this newer development and newer drugs being approved to treat this subtype of breast cancer. Another type of breast cancer that I'm going to talk about is HER2 positive breast cancer. Like I mentioned, if someone have a HER2 positive breast cancer, then anti-HER2 therapy, okay, might be part of the treatment. So anti-HER2 therapy can be used in the early stage, where it can be given as a neoadjuvant, meaning that it can be given before the surgery, or it can be given after the surgery. So it's very much depending on individual case by case basis. So it can also be used when a patient had already an advanced stage HER2 positive breast cancer. So some of the example of anti-HER2 therapy being available is like trastuzumab, TDM1, pertuzumab, lapatinib, and the others. And finally, the other less common subtype, but the more worse prognosis subtype is actually triple negative breast cancer. So in triple negative breast cancer, because there's actually no hormone positive and the HER2 is actually negative, so you can't use the hormonal therapy or the anti-HER2. Therefore, you're only left with the option of chemotherapy and immunotherapy. So if let's say someone is being diagnosed with triple negative breast cancer at the early stage, then chemotherapy is the only choice. And if someone being diagnosed with recurrence or advanced stage, then you can potentially use immunotherapy plus chemotherapy combinations, which I will also talk about a bit more later on. So now goes to one of the main topics for our talk tonight, which is what is immunotherapy. I'm sure many have heard before about chemotherapy, radiotherapy, hormonal therapy, but immunotherapy actually is not something very, very new per se. Immunotherapy has been available in our country or worldwide over the last 10 years or so, but immunotherapy in breast cancer, it is something quite new because they only get the approval for treating triple negative breast cancer recently by the worldwide authorities like the US FDA or the European EMA and in Malaysia itself. So let me elaborate a bit more on what is immunotherapy. So in our normal body immune system, okay, cancer cells actually look very similar to healthy cells, okay, and but when the body immune system, the normal body immune system, detect this abnormal cell, which is the cancer cells, what happened is that they will screen them, okay, and then when they detected that actually there's an abnormal cells like the cancer cells, okay, what they do is that they will actually eliminate it, okay, like the diagram. So that is by right what our normal body immune system should be able to do. But of course, unfortunately, is that that's not the case. So in real life, what we have noticed or the scientists have noticed in the lab is that our bone body immune system are actually not recognizing all those cancer cells, or else there won't be any cancer cells present, right? So what happened is that they noticed that these cancer cells are able to actually escape the detection of the body immune system. So the question is how they do it. So the scientists doing more research in the lab, they realized that one of the mechanism or one of the way these cancer cells did was that they actually try to cover up themselves, okay, and then they use the other things called the signal jammer, which is actually the PDL1, okay, which I will elaborate a bit more later on. And then they try to disrupt the immune system. They try to mask themselves up from the immune system so that the immune system are not able to function properly and not able to detect them. So because of that, there comes the invention of immunotherapy. So the immunotherapy is actually a very broad term in terms of for a systemic treatment. So generally, when we talk about immunotherapy, specifically the treatment that we are talking about to treat breast cancer, we are talking about this class of drug called immune checkpoint inhibitors. So what happens is that in the checkpoints, okay, this drug will actually disrupt so-called like this this masking mechanism that is being used by the cancer cells to avoid the detection of the immune system. So what they do is that they try to unmask it. They try to make them being recognized by the cancer cells so that the cancer cells can be detected by the immune system and the immune system can go and capture it and destroy it. So that is actually how immune system works. Looking at the diagram, just like it. So what is so much different compared to chemotherapy and immunotherapy? So chemotherapy is actually the drug itself that goes and kill the cancer cells. So in the process, they also might affect some normal cells temporarily, and therefore you have some side effects, like nausea, vomiting, hair loss, depends on which drug you are talking about. But immunotherapy, they actually doesn't go and attack the cancer cells. They actually are being injected into your body, and then they actually enhance your body immune system, like the mechanism that I mentioned earlier. And then their own body immune system actually is the one that go and detect the cancer cells and destroy it. So because of that, the side effect of immunotherapy and chemotherapy will also be very much different. So here are some of the common questions on immunotherapy in breast cancer. So can immunotherapy be used in all stages of breast cancer? The answer is actually no. So at this moment, immunotherapy has been only approved for the treatment of advanced triple negative breast cancer subtype. And triple negative breast cancer, like I mentioned earlier, is one of the poorer prognosis subtype. However, with lots more development and advancement in science, the role of immunotherapy in different stages and different subtype of breast cancer is being tested every single day. Okay, but as of at this moment, immunotherapy is only being approved for the treatment of advanced triple-negative breast cancer subtype. So is immunotherapy for advanced triple-negative cancer subtype available in Malaysia? Yes. Okay, so actually it is currently available in Malaysia. Okay, and it has been approved. And can all advanced triple-negative patient uses immunotherapy? The answer is actually no. This is because in the study that tested this immunotherapy on the triple-negative breast cancer patient, it was found that this immunotherapy only works in those patients who have the PD-L1 positive triple-negative breast cancer, meaning that they are only work in those patients cancer cells that uses that particular mechanism to avoid the detection from the immune system. That means the PD-L1, the one that we showed earlier, the masking, or the signal jammer, which is what we call the PD-L1. So only those triple-negative breast cancer cells which uses this particular mechanism, then this immunotherapy will work. If for those triple-negative breast cancer cells that doesn't use this mechanism to avoid the detection from the immune system, then the immunotherapy actually won't work. So patients do not need chemotherapy if they have immunotherapy. Actually, no. In the advanced triple-negative breast cancer, immunotherapy is actually given together with chemotherapy for them to work. Yes, immunotherapy might be able to be used as a single drug in some other subtype of, in other types of cancers, like lung cancers and things like that. But right now, at this moment in time, for breast cancer, they have to be given together with the chemotherapy before it can work. And it can only be given in those advanced triple-negative breast cancer patient with the PD-L1 positive. So, like I mentioned to you earlier, immunotherapy, even though the mechanism of action is very much different compared to chemotherapy, they do have their own side effect. And the side effect is being called the immune-related adverse event or side effect. So generally, what are the side effects of immunotherapy? Is that they actually enhance your own body immune system. And sometimes what happens is that your body own immune system is so strong that actually the immune system attack back your own body. So it can attack any of the organs in your body, or they can attack more than one organ at one time. But generally, immunotherapy is something more tolerable compared to chemotherapy. And even if patient develop the side effect, majority of the patient will only have low-grade side effect, which is easily manageable. But of course, there's always a small risk, probably about 1% or so, where the patient could have severe side effect because of the immunotherapy, and it can be potentially life-threatening as well. So what are the side effects and how do you overcome it? So like I mentioned earlier, so the side effects are mainly because of our own body immune system. So how can you actually try to overcome it? Actually, there's nothing that you can do to overcome it by either medications or in terms of diet. There's actually nothing much that you can do to overcome it. So the most important aspect or the most important way to try is actually early recognition of the symptoms and prompt treatment. That means that your doctor should be talking to you about what are the potential side effects that this immunotherapy can cause. And when it attacks every individual organ, like for instance to the lung, then what are the symptoms that you might experience? So if you have experienced those symptoms early, then you can come in and then to see your doctors as early as possible so that it can be treated and managed accordingly. And that itself will increase the chance of to reverse the side effect, and potentially you can continue with the treatment rather than you're not able to recognize the symptoms and then you continue to wait at home because you think that those symptoms are nothing or normal. And then when the symptoms become more severe, then only you go and see the doctors, then it might be too late. So I think in terms of patients education and empowerment, and then explanation on what are the signs and symptoms of all these side effects is very important when the doctors prescribe immunotherapy to their patients. So please talk to your doctors, to find out more about the side effect of immunotherapy if you are planning to be prescribed with this particular drug. And what are the benefits of immunotherapy in advanced triple-negative breast cancer? Why do we want to give it together with the chemotherapy? This is because in that particular study that I mentioned earlier, they have shown that a combination of immunotherapy and chemotherapy actually has able to prolong the survival of the patients compared to just chemotherapy alone. Okay, Therefore, because of that particular reasons, this immunotherapy in combination with chemotherapy has been approved to be used in the advanced stage triple-negative breast cancer patient. So can immunotherapy cure advanced cancer? Actually, no, because like I mentioned earlier, advanced cancers generally we are not able to cure it. But what we try to do is that we try to palliate the symptoms of the patient to make them comfortable, to make them have good quality of life. And at the same time, we try to delay the progression of the cancer and trying to prolong the life of the patient at the same time. But I think with the advancement, it's our dream and hope that all advanced cancer, right, in the future, even though we are not able to cure it, but we are able to control it for long term, just like other chronic diseases like diabetes, hypertension, and patients can continue to have good quality of life for a very long time. In fact, if you look at the advancement in terms of science over the last 1 decade or so, you can actually already start that, we are moving towards this direction. Cancer that has been not able to be cured completely with very poor outcome, like once a patient has stage 4 cancer, and then most of them will pass on within a year. But nowadays we have treatment coming in which potentially can control the disease for up to years. So we hope that in the future, with more advancement, we are able to achieve this dream. So finally, what are the take-home messages for my presentation tonight is that I think breast cancer is potentially a curable disease if detected early. So early screening is actually very important. And in fact, it should be utilized by all the ladies because not all cancers actually has a screening tools or screening program, which is effective. So start from yourself. Please do the breast self-awareness, which is the look, feel, and respond. And if you are those who falls under the age group which is suitable for the mammogram screening, please do so. And for those who have high risk features like I mentioned earlier, okay, or high risk factors, so please do the screening earlier as well, okay. And subsequently, breast cancer is not one disease. Therefore, the treatment is very much individualized. So it's very much depending on the stages, the subtype, patient's factors, and everything. So in breast cancer itself per se, immunotherapy at this moment is only approved for advanced triple-negative breast cancer, okay, with those with the PD-L1 positive, which is the signal jammer and the masking. So talk to your doctors on whether you are suitable or not, because we can actually do tests to detect whether you have this PD-L1 or not presence in the cancer cells. And finally, immunotherapy together with the chemotherapy has to be given together, all right, in the advanced triple-negative breast cancer for them to be able to give you the superior survival advantage. And with that, I thank you.
Thank you, Dr. Tan, for all the information you've shared with us. It's not very easy to understand the mechanism behind immunotherapy, but I think we get the idea that something like disguise method, trying to hide itself so that our cells will not, and then immunotherapy is something like a way to enhance our own immune system to counterattack the cancer cell. Something along that line. Am I correct? Yeah.
Correct. Yeah, something along the line.
Yeah, so we will have
so
some
basically,
time. Yeah, you go ahead.
Yeah, sorry. So yeah, I think what I'm trying to say is that because the cancer cells, what they have realized is that one of the mechanism that is being used by the cancer cells to avoid the detection from our own body immune system is the mechanism that I mentioned earlier through the PD-L1. So what happens is that this immunotherapy, they try to act on this mechanism so that the cancer cell is being detected by the immune system so that the immune system can act on the cancer cell and destroy it. So this is actually one of the type of immunotherapy.
Yeah. Okay, so we will have some time for Q&A. While we're waiting for Q&A to come up, I have one question first. Yeah, here. Yeah, because you mentioned the PD-L1, PD-L1 positive.
Yes.
How actually a patient get to be tested? How does it?
So normally, okay, so this test, like I mentioned earlier, is actually to look at the presence of this PD-L1 in the cancer cells. So when a patient had a biopsy or had a surgery, then with the specimen itself, they can actually send and test for this PD-L1. So then the report will come back to tell you in terms of the positivity, in terms of percentage, whether this is a high PD-L1 positive or low or negative. And then based on that, the doctors will be able to tell you whether you're actually suitable or not to use the combination of immunotherapy and chemo.
So it will be through biopsy and lab analysis, right?
Correct.
Yes.
Correct.
Is this test available only in West Malaysia or everywhere else? In like Kuching as well?
I think I'm not too sure whether is it available in Kuching, but even in West Malaysia is actually available in the private hospitals, because for them to conduct the test, they need to go through a process to get the lab accredited, so that their results are reliable. So I think even in West Malaysia, there's only 1 or 2 labs at this moment are able to perform this test. And I think even for this test, I think it's being subsidized by the pharmaceutical company. So yeah, so for those patients which you think is actually potentially suitable to use these immunotherapy drugs, then they can actually send the specimen there to get it tested.
I see. So looks like people in Sarawak will have to send their samples via the doctors here to West Malaysia lah. Most likely.
Yeah, I think maybe probably for now, yeah.
Okay. Yeah. So now we open to the floor. Anyone who have any question, you can wave or just unmute yourself if you have question that you'd like to ask verbally. But if you are really too shy, you by all means put down your questions at the chat box. Yeah. So anyone would like to ask question directly to Dr. Tan? It's a very good opportunity for us to learn more about immunotherapy for breast cancer. I know it can be a new topic, but the more we ask, the more we gain knowledge, yeah?
Yeah, actually, I mean, I'm open to any form of question, not necessarily have to be just immunotherapy. I think anything related to breast cancer also, I think I'm open to the questions.
Okay.
I have one question. Are there any studies for the use of immunotherapy for earlier stage cancers?
Yep, actually, there are a lot of ongoing studies right now. In fact, I think there are many, I'm talking about hundreds being conducted in breast cancer. So in fact, it also being conducted not just in triple negative, so they are also being tested on the other subtype like the hormone positive or even anti-HER2 or even the HER2 positive subtype, and in different stages, meaning that not just in the advanced stage, but also in the earlier stages as well. So it potentially in the near future, we might be seeing the role of immunotherapy in combination with chemotherapy before even the surgery, or after the surgery, in those earlier stages cancer.
So that will be sometime down the road lah, not now lah. Now is actually for advanced stage. Okay.
Yes, because those are ongoing. So I think these are all the processes that the drug development has to go through. So same things for this particular immunotherapy in triple negative breast cancer. They have gone through the similar stage as well prior to this before they are being approved to be safe to be used in patients.
We have one question from Mandy Yong. Says, WHO has warned us on the effects of taking tamoxifen after 5 years can cause cervical CA. What's your comment on this?
Okay, I'm not too sure whether the tamoxifen after more than 5 years can cause cervical cancer, but for my understanding, it's more of like uterine cancer or uterus cancer. It's not actually cervical cancer. So there's been a lot of studies being done to compare taking tamoxifen for 5 years or up to 10 years. So generally, I would say that depends on how you look at it. So the side effect from the tamoxifen is that actually the side effect from the tamoxifen, if you to use 10 years compared to 5 years, is that there's actually a 2% increment in terms of the risk of getting uterine cancer, i.e. meaning that example, say I have 100 patients here taking tamoxifen for 5 years. So out of the 5, say 2 of them get uterus cancer because of the usage of tamoxifen. But in another group of 100 patients using tamoxifen for 10 years, then you will see that there are potentially maybe 4 patients will have this uterus cancer because of the prolonged usage of the tamoxifen. So generally, you are talking about a 2% increase. So normally we don't think that all patients should get 10 years of tamoxifen. So it's generally being recommended in those patients with high risk of recurrence. Then the doctors will actually recommend the usage of 10 years rather than 5 years. Because when we make that decision, it's normally after we weigh the benefit compared to the disadvantages. So in that particular case, we might think that, that 2% increment in that risk is actually low compared to the benefit of reducing the risk of the cancers to relapse. So in that particular case, then the doctors might actually recommend that.
Stephanie has a question. How long has immunotherapy been used as a breast cancer treatment? I think you went over this.
Like I said, I think this immunotherapy combination in triple-negative cancer has been approved in Malaysia this year itself, and it has been approved in the US and the Europes a year before that. So it is something relatively very, very new. Okay, so immunotherapy for breast cancer, like I said, is fresh from the oven, at least in Malaysia. It's just actually started being approved this year itself. Yeah, but in the other countries, it's being approved probably about a year or so prior to that. So generally, whatever drugs being approved by the US FDA or EMA, it will probably take about a year or a year and a half before they actually being approved and reach Malaysia itself. But having said that, a lot of times is that once they have been approved by the world regulatory, like the US FDA, even though it has not been approved or indicated in Malaysia yet, but sometimes we do have access to all this drug through a special program, and then to bring it in for use of our patients here, if let's say the patients are actually suitable to use for that particular drug.
Jim has a question. Does a high soya-based diet increase the risk of breast cancer?
I think from my understanding is that there's no much scientific evidence to suggest high soya-based diet can actually increase risk of breast cancer.
Chu Jin has a question. If additional survival benefits of post-chemo is 0.8% in 10 years, based on NHS breast prediction, versus second cancer post-chemo risk of 3.8% in 5 years, 7% in 10, does the risk of chemo outweigh its benefit? What is your opinion?
Okay, so generally, I think this question is a bit quite, I'll say, general. I think, but what I can tell is that normally when a patient has a breast cancer, especially those with borderline, meaning that intermediate risk, they are not the low risk and not the high risk, intermediate risk, then what we do is that we will actually do an assessment based on the multiple factors like the patient's age, whether how they detected the cancer itself, whether by screening or by symptoms, and then what are the other factors in the breast cancer itself, like the size of the tumor, any lymph nodes involved, whether this is actually a hormone positive or HER2 positive, and then looking at all these factors, then we will actually tabulate and come back to say that, if you were to offer chemotherapy for this particular patient, what is the benefit? So generally, if let's say the benefit of the chemo is 2% and lower, normally we will not recommend the chemotherapy for the patients. So, but if let's say it is something which is more than 5%, normally we will say that the benefit is actually higher and outweigh the risk. And if let's say it's somewhere between, which is 3 to 4%, then normally what we do is that we will actually explain and talk to the patient about this particular benefit in terms of the survival, in terms of the percentage, and then what are the risks in terms of the side effect from the treatments that's come together with it, and then we will talk and let the patient decide.
I hope that answers your question, Chu. Mandy has a follow-up question. How is immunotherapy given to patients? Is it by injection? For how long?
Okay, immunotherapy. So for this moment in time, immunotherapy is actually given through injection, through IV, intravenous. So it's given every 3 weekly. It's given 3 weekly, and like I mentioned, because it's in advanced triple-negative breast cancer cases, so at this moment in time, the recommendation is actually to give 3 weekly together with the chemo, and then subsequently you just stop the chemo after, say, 4 or 6 cycles, and then you just continue with the immunotherapy along until it actually doesn't work. And in terms of the cost of the immunotherapy, in this particular triple-negative setting, the immunotherapy itself costs roughly about 10,000 per cycle.
Wow. 10,000 every 3 weeks. You mean?
Yep.
That's a very huge.
Yep. Yes.
Mm.
Yeah. There are some who are actually even more expensive. Other immunotherapy in other tumor types are actually even more expensive.
Mm. I think that's a question. How often to check the uterine?
Uterine.
Uterine,
So
sorry.
generally is that generally is that we don't routinely check the uterus when a patient. I assume that this question is a follow-up from the earlier questions when the patient is on tamoxifen, where there's actually an increased risk of getting uterus cancer. So actually, we don't routinely check the uterus when the patient is on tamoxifen. So normally, what we will suggest is that if the patient actually fulfill the criteria for cervical cancer screening, by all means, they still should go for their pap smear and things like that. And what we normally do is that if the patients come in with symptoms of suspicious of something not right with the uterus, is that they might come in with, say, prolonged menses, or those patients who have actually stopped or become menopause, and then suddenly they have menses coming in. So these are the patients that we actually think that there's actually a risk of developing the uterus cancer, and then we refer them to our gynecology colleagues to do further tests. But we don't routinely have a scheduled kind of thing to check all these patients, because if you look at the risk itself, is actually very, very low. So in my practice, all these years using tamoxifen for more than hundreds of patients and things like that, I have not seen patients who develop uterine cancer because of tamoxifen. But there are some patients, a small percentage of them, which actually develop this so-called hyperplasia or thickening of the uterine lining, and therefore they have this problem with bleeding, but it's actually not cancerous. So what we do is that we will actually change the tamoxifen to other hormonal therapy.
Maybe a follow-up on this question. Is the patient able to send something like a symptom if there's some issue with the uterine lining, the lining issue? Are they able to like bleeding things like that?
Okay.
Will there be some
Sorry,
form of I mean, follow after this question from Deswi. Is there a way a patient can detect some abnormal symptoms since the check or examination is not commonly used?
Like I mentioned, is mainly they're going to be present with abnormality in the menstruation or bleeding. So that is the most common symptoms that you will be seeing. Let's say they do have problem with the uterus.
Okay. So overall for breast cancer treatment, right? The patients or survivors after years, right? I do hear some come back to say they do have bleeding problem from time to time, with or without having a hormonal treatment. What do you think could be the cause of this bleeding?
Oh, okay. So I think in that particular case, I suspect is that because in some patients, actually they have not attained menopause yet. So they are either premenopausal or perimenopausal. And because of cancer treatment, especially chemotherapy, they actually can disrupt this menstruation cycle. So patients who are on chemotherapy, you tend to hear them saying that, suddenly their menses have stopped, even though they have not reached menopausal state yet. So, or sometimes you can see a disruption in the menstruation, like, all this while they have been having regular menses, once a month, and then suddenly now they have this spotting for 1 or 2 days every 2 weeks and kind of thing. So these things are actually quite common, especially on patients who are actually not attained menopausal status yet, and they are on chemotherapy. That is because of the hormonal changes in the body because of the chemotherapy.
Okay.
Yeah.
Thank you.
No problem.
All right, the next one is from Mandy again about claiming of insurance for immunotherapy as a new cancer treatment type in Malaysia. Is it covered under insurance?
I do not know, because I think that even for insurance there are different types. But all I can say is that definitely there are some of my patients who are actually on immunotherapy and is being claimed from being paid by the insurance. Yeah.
How many patients do you have currently undergoing immunotherapy?
For breast cancer itself, I don't have any particular patient for the triple negative at this moment in time. But for other tumors, I have actually quite a number of patients, especially in the research that I'm actually doing.
This question comes from Facebook. Rukesh asked, does Avastin cause hydronephrosis?
Hydro what? Does which drug again?
Avastin.
Which drug?
Avastin.
Does
A-V-A-S-T-I-N.
Avastin cause hydronephrosis?
Yes.
I don't think they actually cause hydronephrosis, but what Avastin does is that they actually can cause proteinuria, meaning that there's actually presence of protein in the urine itself. That is one of the known side effects for Avastin, or bevacizumab we call it. So generally patients who are on Avastin, okay, they will need the urine test every single visit to look at the protein presence in the urine itself. And if let's say the protein is very high, then they might need to stop the Avastin. But I don't know of anything that Avastin can cause hydronephrosis. Yeah.
Casey Wong has a question, which is more suitable for early stage breast cancer for postmenopausal women, tamoxifen or letrozole?
Actually, I would say that both has its own side effect profile, which is a bit different. For tamoxifen, it's a bit more on, like I mentioned, risk of uterine cancer, and then risk of making your blood a bit thicker. So there's actually slight increased risk of getting a stroke or slight increased risk of getting a heart attack. But all these risks are actually very, very small, even though it sounds scary. Whereas letrozole itself don't have any of these side effects, but they can potentially cause the bones to become osteoporotic, okay, or osteopenia we call it, so that there's actually risk of getting fractures of the bone if you have prolonged use of letrozole, which is under the aromatase inhibitors. So normally I would say that we will let the patients to decide on which they actually prefer. So if let's say patients are on letrozole, sometimes you might need to give them some bone strengthening agent at the same time, which itself come at additional cost or side effect. So I'll let the patient actually decide. But in terms of tamoxifen and letrozole, actually there's not a lot of difference in terms of its efficacy in preventing the cancer from relapsing. Yeah, but generally, people might think that letrozole is a bit better than compared to tamoxifen, but I wouldn't say that the difference is actually very big.
I hope I didn't miss any, but I think last question here is from Wendy. Can a patient get pregnant while on tamoxifen, or does it have to be after 5 years?
Okay, generally, we do understand that in terms of the treatment is very much individualized. So even though a doctor might recommend that, saying that, okay, you need to take this tamoxifen for 5 years to reduce the risk of the breast cancer to come back. But we also understand that, as a normal human being, we still need to continue our life, and we hope that we can continue our life just like a normal person of our age. So that's including marriage, childbearing and things like that. Especially, we want to childbear at earlier age rather than wait until after 40s or after you complete the 5 years. So normally we actually allow the patient to get pregnant while on treatment, but you actually need to talk to your patient doctors prior to that, and we actually have to stop the tamoxifen. Okay, recommendation is to stop it for at least 6 months before you actually try to conceive. Okay, because tamoxifen has been known to potentially can cause some effects to the babies, but of course, again, the risk is actually not very high, it's actually low. But if let's say there is something that we can do, what we try to do is that we try to lower it even further by stopping the tamoxifen at least 6 months prior to trying to conceive. And of course, having said that, we also need the patient to understand that by stopping the tamoxifen and during the pregnancy itself, there's always an increased risk of the breast cancer to relapse or to come back as well. So after having this kind of discussion with the patients, and then if they understand and if they say they want to continue to get pregnant and things like that, we will support the decision and do the necessary.
I hope that answers your question, Wendy. Kuching has a follow-up question. I think this is a different topic. What's your opinion on the Oncotype DX test? Is it reliable?
Okay, Oncotype DX test is actually additional test, which is not something which is available in the government hospital, public hospital. So it is something that can be done in one of the private lab again. So it will incur additional costs. So like I mentioned earlier to you, at this moment in time, Oncotype DX, one of the major role is actually to determine whether those patients with early risk, low risk or intermediate risk, whether they actually should go for chemotherapy after surgery or not, or they can just do away with hormone therapy, without the chemotherapy. So so that is actually one way that will help you to determine whether you actually need the chemotherapy or not based on the study itself. Okay, because once you do the Oncotype DX, they'll come out with a score and then tell you that what is your score like, and then based on the scoring, then you can say that okay, this patient is actually has low risk of the disease relapsing, so you can actually do away with the chemotherapy and just give hormonal therapy. So another way that I mentioned to you earlier is that in the hospital, what we do is that we use a formulation. Okay, this formulation is being not by us ourselves, it's actually by the NHS UK. Okay, we call it one of the predict tools. So after entering all the information of the particular patients, like the name, like the age, the symptoms, and then the tumor characteristics like the size, the nodes, hormone receptors, HER2 status, and all these things into it, then that one itself, they actually will come out and tell you that, in 5 years' time, or 10 years' time, the additional benefit of adding on chemotherapy compared with just hormonal therapy itself, like how many percent benefit. Then based on that, we will actually recommend to the patient to say that, okay, in your particular case, the benefit of adding on a chemotherapy is actually more than 5%, then therefore, it's good for you to have chemo together with hormone. Or if let's say the advantage or the benefit is actually very low, lower than 2%, then we'll say that, okay, for your particular case, maybe chemotherapy is not needed, then you probably can just do away with hormone therapy. Yeah. I hope I answered that question.
On this Oncotype DX, which is fairly new to me as well, I just wonder how accurate is this so-called test? How accurate that? How much trust?
Actually, like I mentioned to you, is that the test itself, they will just come out with the result in terms of scoring. So actually, it's because a study has been done to use this Oncotype DX as part of the test, and based on that, they actually classified the patient based on the scoring that is being received from this test. And based on the scoring, they will make the recommendation on whether the patient need chemotherapy and hormonal therapy or not, or just hormonal therapy alone. And based on that result from the particular trial, therefore the role of Oncotype DX came about, you see. So the test itself is actually just to tell you the scoring. It's actually the study that is being conducted is the one which is trying to tell you that, whether you need the chemo or you actually doesn't. Yeah.
So it has to be a decision-making process between the doctor, the oncologist, and the patient, based on the result given.
Yeah, but generally it's very much on those patients who are intermediate or low risk, because for those patients who have high risk, normally I don't think the patient actually need this Oncotype DX because it's quite clear cut that the patient will require chemotherapy after surgery, you see.
I see. Okay.
Yeah.
Yeah, I understand there's also a question from Facebook Live from Teresa He.
Yeah.
The question is, when you do combination of the two therapies, which is immunotherapy plus chemotherapy, will immunotherapy boost up our immune system to attack the cancer cells and then reduce chemo side effects like no hair loss? And the next question will be, with two therapies together, definitely cost will be much more higher and higher. So what's your answer?
So yeah, I think the cost is high, definitely, like I mentioned to you earlier, because you need to perform the PDL testing. That itself will incur some cost, and then of course with the cost of immunotherapy itself is actually quite substantial, especially it's not like chemotherapy, you only do it for 6 cycles or so. So you actually need to continue taking that as long as it actually helps to control the disease. So it's very hard to predict, what are the total costs that is being needed. So in terms of the questions on the side effect, so actually generally what we explain to patients is that they actually help to boost your immune system to go and attack the cancer cells. But in actual fact, it's actually not boost up your whole body immune system, but it's more of like to act on that particular checkpoint area, the one that I mentioned earlier, and try to unmask the mechanism being used by the cancer cells to avoid detection from the immune system. So it's actually acting on that particular mechanism itself to unmask the cancer cells. So it's not so much, in fact, on actually to boost up your own whole body immune system so that you won't suffer any side effect from the chemotherapy.
Okay. Yeah, I think we have Wendy has a question. She would like to ask live. So Wendy, please unmute yourself. Wendy.
Okay.
Yeah, no problem.
Hi, doctor.
Hi.
After I finished my chemo and radio 10, 15 years ago, I actually went to see an oncologist in your hospital, the Chinese medicine, 肿瘤科 博士.
Okay.
And she actually, that was after my radio, then she actually recommended some herbs and all that for me to take, and I brought some back to Sarawak and boil and all those type of things. What do you think if for now, but I only take about a few, because then one of my doctor's friend was telling me that, do you know what's the content in there and all that? So in the end, I stopped taking. But now people are saying that we can have alternate, like not treatment, but while doing chemo and all that, can we take those type of Chinese herbs? As prescribed by
yeah, I think the thing is that I mean, I'm not an expert in the TCM or the alternative specialty, so I can only recommend based on what my own understanding is that number one, like you mentioned yourself just now, sometimes what happens is that we do not know what are the active ingredients in those supplements or herbs that you are taking. Even if you were to purchase those off-the-counter products in the market, sometimes they have this labeling there on their content. But having said that, whether they have actually labeled out every single ingredients in that particular products or not, we are not too sure as well. So to be on the safer side, normally what I would recommend to the patient is that when the patient is actually on active treatment for the cancer, like chemotherapy, I will not recommend the patient to take in any form of herbs or Chinese medicine, any form of supplements that people recommend is good for cancers, or even, Chinese, sometimes we say that, certain leaves you boil with water or whatever, and that kind of thing. I will ask them to actually not to take any of those, especially while they are on treatment, not just on the day of chemo, but during the whole durations. But once you have completed all those, like your case, you completed your chemo and radiotherapy, and if you would like to try on that, I will leave it for the patient themselves to decide. Okay. And actually, in terms of the role of traditional Chinese medicine in helping out the patient during the chemotherapy period, mainly there's actually some role. Mainly is more like acupuncture, that kind of thing, which will actually help to reduce the side effect of the chemo, like nausea and vomiting. Actually, it has been proven that all this like acupuncture actually helps. But normally, we will not recommend anything which require you to take in while you're on cancer treatment.
Yes, thank you. Because I am now in Miri. I'm from Miri, Sarawak. I'm now like doing counseling for a lot of new patients who wants to know more about treatment and all that. So we're just helping them. So there are some things that we need to know also, So I've been through that. So
Sure.
I was thinking that if your supplement can help, now is a lot of people saying that Kangen water, or all sorts of water and all that. I say if this can help, there won't be anybody who will have cancer, breast cancer. So there's a lot of things that we have to learn.
Because I think, because the thing is that I think one of the things that all these people who are selling all these supplemental products is that they will always claim that the products are all natural, and then chemotherapy, a lot of side effects and things like that. But just to let you know that I think one of the chemo drugs which is commonly being used in breast cancer patients, which is what we call the taxanes group, I think the name like docetaxel, or taxotere, or paclitaxel, probably some of you might have heard before. In fact, actually, this chemo drug is actually derived from plant. you see.
Oh, okay.
So there's actually no such thing as a natural product which has no side effect, or safe for the body and kind of thing. So yeah, so normally I will try to use this example to explain to my patient who's saying that, oh, doctor, this product is actually natural. It's all from plants, you see, there shouldn't be any side effect kind of thing. Yeah. So just have to be careful with what you are taking.
I would like to add to that.
Thank you,
One of
doctor.
the alternative treatments people have
No
is
problem.
apricot seeds, and those are full of arsenic. So it's natural.
Arsenic, I think the reason people recommending the apricot seed is because they think that the apricot seed has high vitamin B12 content. It's not so much on the arsenic, you see. So of course, this is one of the I'll say alternative treatment that you keep on hearing a lot in the social media. I think apricot seed is being one of it. Of course, Sabah snake grass is something that you commonly heard. Vitamin C injections. There are all sorts of things. But like I said, all these are not proven scientifically. And one of my professor before when I was doing my specialty is that he always jokes that saying that one day he might even considering coming up with something from the durian seeds, because that year during the durian season, we have a lot of seeds left behind, together with the shell and things like that. So if let's say we can have something coming out from it, then probably we can make a lot of money, you see. So I mean, just a joke. Yeah.
Casey Wong has, I think this should be the last two questions. Casey Wong has a question. Is it okay to take Chinese herbs while on hormone therapy?
I think this one is also, I answered this particular question earlier as well. So I think that it is a very much gray area, because I will say that, again, I'm not sure what are the active contents of the Chinese herbs, because as you know, that herbs itself, sometimes they have steroids and things like that inside, which potentially might also affect the hormones of the inside the body itself. So it might potentially cause some interactions with the drug that we are giving as well. So as long as a patient is on something systemic, meaning that something that you are taking from the Western medicine side or the anti-cancer treatment, normally I try to recommend to them that not to take any form of herbs or supplements to help them out. But I mean, if you were to take something like bak kut teh or herbal tea and things like that, I think that one is completely fine, but not something specifically for the cancer itself, reduce the risk of the cancer to come back kind of thing. Yeah.
Kuching has a question on how soon should you recommend the daughters of breast cancer patients to start breast cancer screening, and how frequent?
So, yeah, so I think that if let's say someone has risk factors of in the family, in the first degree family, so I think you can actually start potentially, by 45 to 50, you can already go and do the mammogram. And if let's say the first mammogram is normal, I think you can do it every other year. Okay, but at the same time, while doing the mammogram, you are actually advised to do regular breast self-examination, like I mentioned earlier, the breast self-awareness, meaning that you actually look, feel, and respond. So the frequency I would recommend is normally, I would say that, you try to do it at least once a month after your menses or after your period, when the breasts are not so engorged. And then the easiest way to do it is actually when you are trying to take a shower. So when you are fully undressed, in front of the mirror, you can try to observe and look at both the breasts, whether is there any new changes, any dimpling, any skin changes. And then after you apply on the body soap, okay, or body shower, when it's actually easier for you to actually using the three part of these three fingers, and then through a circular movement from outside all the way in to the nipple area, and then at the same time you just feel over the armpit axilla side as well at the same time to feel whether is there any lump or any abnormalities that you have not felt prior to this. Yeah, so that will be my recommendation. But of course, if let's say a patient itself actually was diagnosed with cancer at very young age, then there's actually a higher risk that they might potentially have these genetic abnormalities. So in that particular case, then maybe the daughters or might need to actually go in and conduct the screening much, much earlier. So actually, it's not just one factor, but multiple factors. So I think it's advisable to actually for the patient to actually to talk to their doctors, treating doctors, to assess their risk on whether is there a need for their family members to come in earlier to do the screening test.
I think that should be the final question.
Well, may not be the final one. I just have one. Yeah, it's
Yeah, no problem. It's okay.
yeah, in terms of immunotherapy, we know it's relatively new in Malaysia and for most of the cancer treatment. It seems that it has been making a little bit of inroads for other some of the cancer types, like for example, lung cancer, perhaps. What are the cancer types that immunotherapy has started more in a more matured manner? Maybe you can share with us a little bit more about that for our knowledge.
Okay, so I think no problem. So I think in terms of immunotherapy is that they first started off using it in tumor types which has high mutational. So I think one of the earlier tumor types that they started on is actually skin cancer, which is the melanoma. But melanoma is not something so common in the Asian context or in Malaysia itself. So we actually don't hear many, or we follow up a lot of all this development in the melanoma. And the, like you correctly mentioned, is that I think one of the subsequent tumors that has been using immunotherapy since some time ago is actually lung cancer. So in fact, in lung cancer, immunotherapy has changed the landscape on the treatment for certain subtype of the lung cancer itself dramatically. So for instance, in one of the subtype of lung cancer, if someone being diagnosed at stage 4 years ago, just say 10 years ago, okay, generally we say that, despite whatever chemotherapy this patient has, within 1 to 2 years time, almost 100% of the patient will pass on. But with the immunotherapy on board for this particular subtype of lung cancer patient, right now we have data to show that, up to 20%, 20% of the patients actually are still around after 5 years when they're on this immunotherapy, which is something that we have not seen before with other drugs or other treatment for lung cancers. So because of all these advancements, so nowadays immunotherapy has been approved in a lot of solid tumors, not just in lung melanoma or breast, but also other types like head and neck cancers, kidney cancers, bladder cancers, and a lot more. And then in fact, every single site or every single type of cancers, there are actually a lot of advancement or development or studies being done at the same time right now to see whether can they be used in other combination, in different stages, whether is it stage 4 or earlier stage, that kind of thing. So I think in the near future, we'll be seeing a lot more usage of immunotherapy in different tumor types, especially in breast cancer as well.
Okay, so I would say the outlook is pretty positive. It's just a matter of time before we get on to more effective treatment for breast cancer and other cancer types. Am I correct?
Yeah, definitely. Yeah, definitely. So I think my advice for patients who are with stage 4 disease, don't give up, because I think, like I said, things are being developed every single day. Advancements are being done every now and then. And so things which is not possible today doesn't mean that it will not be possible in a year time or 6 month time and things like that. We just never know. So I think don't give up. Just try your best to, get yourself treated, and then with a positive mindset, and then hopefully, by the time that the current treatment doesn't work, then you have more new options available for you, which will help to control the disease for a longer time. Yeah.
Thank you so much, Dr. Tan. I don't think we have any other last question. Yeah, Chris, any more from Facebook? No?
No, I think that's...
I have one last question, Doctor.
Oh.
Please.
How do we encourage more women to go for mammogram?
Oh, this is something. This is something even beyond me, because
I know.
I think that it's more of like the mindset, the cultural belief kind of thing. Because I think cost is definitely not an issue anymore, because there are a lot of NGOs or programs or hospitals are offering free mammogram screening. In fact, we have a mobile mammogram truck, which is actually trying to go to all these rural area to try to provide them with this mammogram, free screening and things like that. But having said that, even with all this initiative that is being done, many are still not willing to come in to get the screening or mammogram done. And and every month or every year, we are still seeing patients coming in with a huge fungating breast mass tumor, sometimes with even maggots, or bleeding and that kind of thing. And because they have been keeping it for years. So I think, yeah, I just hope that, at least for the newer generation, younger generation, with the availability of social media and the patient's education and things like that, hopefully all this will change in the future. Yeah.
Sister Boon Lui, I think we should do more on this. Like I do this every year during October. That we go to shopping mall and give out pamphlets. I think we set up booth and all that. That's a way to help also, isn't it?
Yeah, I
It's
think
just
the other
so
way,
sad,
yeah, is to use the real story to tell people.
Definitely.
Share our stories, cancer survivor stories. To encourage others, not just stories, it's real story, real life stories. yeah. It will take some time, but we have to keep
we have to educate people more.
Yeah, the education will never end. We have to just continue. Yeah, we continue to do webinars like this, and then sure when we have Dr. Tan has got to know more about new breakthrough in immunotherapy, we definitely would like to invite you to come back and share with us more so that we know what is new in the marketplace. Yeah. So thank you very much, everyone.
I'm more than happy than to share.
Yeah. All right. By the way, Chris has actually sent out a link to our e-feedback form. So for all our ladies and gentlemen out there, please feel free to fill in any feedback or suggestions so that hopefully we can make our webinar in the future webinars more effective, more informative and helpful for everyone. Yeah. So thank you, ladies and gentlemen, and big round of applause to Dr. Tan.
Thank you, Dr. Tan.
Thank you. And have a
Thank
good night rest, everyone.
Thank you for having me.
Take care and stay safe.
For
Bye.
introducing us.
Thank you, Purui, Chris,
Thank you
Dr. Tan.
everyone
Bye.
for coming.
Bye.